Hi, I'm Joyce Burello, and this is Vanessa Barahona, as our convener said. We're both cancer care coordinators at Prince of Wales Hospital, and in this project we work together with Elizabeth Brown, our nurse manager, and Leon Watts. We're going to present to you today the mapping and the implementation of the generic cancer care coordinator at Prince of Wales Hospital. We start with giving you a bit of an overview, what we'll be presenting today will be a bit of the background of cancer care coordinator, the new role implementation of a generic care coordinator, the referral process that we put in place, our patient priorities, some of our achievements through captured activities and through a patient survey, and moving forward. So the background of the cancer care coordinator at Prince of Wales was started in 2002. It was acknowledged that by the optimizing cancer care reports that patients and carers can become lost in the complexities of the health system. Sorry, I didn't push the slide. In response to this report, the cancer care coordinator roles were introduced. At Prince of Wales, the role started in 2004 with two full-time positions, one a full-time in gastrointestinal tract malignancies and the other one for part-time in lung cancer. Later on, a brain cancer care coordinator joined the team. In 2015, after the South East Sydney Local Health District reviewed the position, and to align with the South East Sydney Local Health District Cancer Clinical Services Plan for 2015-2018, together with the Cancer Institute Cancer Success Factors, tumor stream care coordination were converted to generic care coordination. I don't know what I did. Okay. No, it's gone forward. Sorry. No, it's not in order. Sorry, the slides are not in order anymore, so I don't know what's happened to it. I'm going to speak to it. The role of the generic cancer care nurse coordinator at Prince of Wales commenced in the middle of November 2015, with 2 out of 3 positions being filled, recruited. This continues for the first 6 months of the cancer care coordination because the third position could not be filled. Our aim was to capture the majority of the solid tumour patients that come to us, including hematology cancers. However, we excluded the breast, gynae and youth services, cancer services due to other services being available. As we started to do of us, we decided to alternate on the weekly intake of patients presenting to our services regardless of the cancer type, as long as they had a diagnosis, while the other person carried the pager and answered other forms of referral. The way we went about it was that we set up our information system, which is Mosaic, and I see mostly here people use that system, to help us to flag all patients who come in with as new patients. We go through the list in the morning and identify those patients who have already had a diagnosis, and we go and meet them. Or else if they've already been seen, due to being seen in another, sometimes they appear new on the system, but they've already been seen in another, either in medical oncology or vice versa. So if that patient is already known to one of us, then they will hang on to that patient. The other referral process for those who were not captured during the first visit or who were not yet diagnosed at the first visit were identified as requiring assistance and coordination were referred by medical or nursing staff through other various systems available, including at patient's request. And now I'll give you Vanessa.
Thank you, Joyce. So our patient catchment and priorities. We adapted a cancer care complexity index tool from Professor Krishnaswamy's work from Peter Mac, which is yet to be published, to identify the following groups: Aborigine and Torres Strait Islander, culturally and linguistically diverse, patients from rural and remote areas, patients with multiple modalities, patients and carers with additional psychosocial and psychological needs. This is a graph summary of our patient catchment for the first 6 months. As you can see, we have seen some Aboriginal and Torres Strait Islander patients. 40 patients came from the rural and remote areas. Majority of our patients has psychosocial needs, and there's a large number of patients with culturally and linguistically diverse background. The bottom graph, we also classify our patients from being single modality to multiple modality. Single modality means patient is having treatment with either surgery, hematology, medical oncology, or radiation oncology. And multiple modality is a combination. And the number 24 is the number of patients which transition from single to multiple. This is just a more detailed illustration of the previous slide. As you can see, we break down the categories. So you can see that some of the patient has can fall under 2 categories, 3 categories, or 4 categories. For example, being culturally and linguistically diverse with psychosocial needs. And yeah, there's a lot of combination there. This is our captured activities for the first 6 months between Joyce and I. We base our activities from the hospital's business rule. So we are able to capture our face-to-face consult, email and phone advice, and we can classify them further to hematology, medical oncology, radiation oncology, and as you can see, we can't avoid giving palliative care advice even if we have our own palliative care service. Altogether, we have captured 1,950 activities, and this is just the outpatient activities, and we haven't included the inpatient activities with this data. We have decided to do a patient survey after 6 months of implementation of our service. We use a validated tool from Young et al. It consists of 20 questions on a 5-point rating scale. We have given out 230 surveys in the outpatient setting, and we have received 157 responses, or 68%. These are just some of the questions that we have included from the survey. So out of, more than 80% of the patients felt that they have adequate access to additional services. And more than 80% has sufficient help from staff with dealing with emotional impact of cancer. And they also feel that we pick up if they're feeling anxious or down. Only 10% of the patients felt that professionals looking after them were not fully informed of their progress. In the end of our survey, we have asked our patients to rate the overall coordination of their care, and the result came back in our favor, which is 8.5 out of 10. In summary, We were able to implement the generic cancer care coordinator role in Prince of Wales, which provides effective service. In evidence by, we have high level of activities and we've seen complex patients. Lastly, the survey reflects that the patients appreciate our service. Moving forward, we recommend that we will refine the referral pathways and the cancer care complexity index assessment tool. We would like to promote the cancer care coordination role to the hospital staff and other services. And we would like to do another review after 6 months, now that we're fully staffed. We would like to acknowledge the Cancer Institute, New South Wales, Prince of Wales Cancer Hematology Services for making our service possible, Professor Lynn Perry, for Brett and Pamela for helping us with the data, they're here, and our administration staff for helping us with the survey. Any questions?
Thank you very much for that. Are there any questions? I guess that presentation's a good demonstration that data is power, and it's very important to be able to collect all of the information and the activity that you're doing and be able to utilise that down the track. So well done for that. Yeah, we do have a question.
Yeah, it's more of a statement rather than a question. Hi, Vanessa and
Hello.
Joyce, I know you well. And you girls do a very good job. I find that I'm quite saddened by the role, actually. I feel that it's a backward step in where we're going. I myself am a breast cancer coordinator. I don't believe in taking the care coordination out of tumour streams and just making it generic. I think we've worked towards a model that works in breast cancer, and we heard from our friend in Parks who's got a prostate nurse there, and we're hoping for more tumour stream nurses, and I feel at the Prince of Wales we've just taken a backward step, and I don't know if the Cancer Institute plan on doing anything about that.
Is there a question in there? Okay.
I think you have the right to respond to that statement, but if you don't...
Well, I was a tumour stream care coordinator for 8 years. I embraced the new role. I think what we need to keep in mind is that we're there for patient care, regardless of the tumour or what disease they have. I'm not saying I disagree or that I agree. All I'm saying at this stage, I try to embrace patient care, and that's what I focus on, is patient care, is providing the best that I can do in my current role.
Yes.
I guess based on that, given that you're a tumour stream coordinator before, and now you're more generic, do you find your role in the MDT and perhaps implementing new innovations that become available for our patients is more limited now that you have this more generic role? Do you see, is there any difference perhaps in that real MDT and then bringing those, the latest research and making sure our MDT knows about them? Do you still find you have that role, or is that completely dropped off now?
Well, it's a different role altogether. So for starters, I don't go to all the MDTs. We take turns. So when I'm on catchment, I do not go to an MDT because I have to see about 20 patients in a week, or whoever is there. So there is no time availability so the other person, now that we're full, the other person will go to an MDT. We will pass the information. I think the role in itself has changed a little bit, but again, it's patient care, and that's all it can. It is different than it was before.
Great. Thank you very much. I guess that demonstrates that there's a number of different ways to address similar issues, and I encourage that conversation to continue later on. But thank you again to our presenters.